Spirometry now. Functional respiratory test, done in the outpatient setting usually, but increasingly becoming more common on the wards. And this is a flow volume loop that looks at expiration and inspiration. And it's converted by a computer into flow. So on this y-axis here, we've got flow in litres per second. And on the x-axis, we've got volume. So you notice that when someone breathes out, most of the flow happens at the beginning, and then it tails off towards the end. And this is the inspiratory segment. So we've got a negative flow here and a positive flow on the expiratory. You don't see these that often. They are in exams and they are in books, so it's worth knowing about them. But more commonly, we get this kind of thing. And this is a graph of volume over time. And I've shown here lots of different graphs. The first one, the black one, is normal spirometry. And there are two parameters we want to look at. We want to look at the FEV1, which is the forced expiratory volume in 1 second. The patient does this by taking a very big breath in and breathes out through the spirometer. Keep breathing, keep breathing, keep breathing until it stops. And we usually get about 4.5 to 6 litres of vital capacity. And that's the forced vital capacity, or FVC. The FEV1, though, is how much of that air comes out in the first second. So what volume of air comes out within the first second. And these are different types of defect. There's an obstructive defect and a restricted defect. There are grey areas in between, but we'll go through those in turn. This is normal spirometry, so nice high peak, lots of air coming out within the first second, and it tails off towards the end. So here's it represented in numbers: FEV1, 4, and FVC, 5. So as you can see, most of it comes out within the first second. So that gives us a ratio, or FEV1 over FVC, and this is very important when we come to looking at COPD and asthma later. This ratio says how much of that air comes out in the first second is representative of the total. So in here, the usual is about 70 to 80%, and here this one is 80%. So 80% of that air comes out in the first second. Let's look at obstructive then. So obstructive, we want to look at the FEV1. You can see just by the graph that there's a marked difference in FEV1. The FEV1 for obstructive deficit is much lower than in normal spirometry. But the FVC, the amount that comes out after all the time has elapsed and they've got no more breath left, is nearly the same. Not quite, but nearly. So an obstructive spirometry is characterized by airflow obstruction, and it's not coming out quickly enough, so therefore the FEV1 is reduced. In numbers, that looks like 1.8 out of a total of 4.3, so not very much of the total comes out in the first second, and that's a very obstructive ratio there that we've got, 0.42 or 42%. Everyone has their own predictive values of FEV1 and FVC based on their age, height, and everything else, so don't worry about them too much, the individual numbers. And here's a restricted deficit. And causes for a restricted deficit could be obesity, where you've got lots of mass outside the chest, compressing the chest. May well be kyphosis, if someone's got a very kyphotic spine. That may lead to a restrictive defect, or where you've got lung destruction, such as pulmonary fibrosis, you may get a restrictive deficit as well. And this is characterized by a reduced FVC, but a normal ratio. And let's have a look at that in figures. So FEV1, 2.8, FVC, 3.3, and a ratio sort of normal or high. So the ratio is well preserved. The amount that comes out in the first second is in proportion to the amount that comes out overall in what you would expect for normal spirometry. But the amount of the FVC that comes out is very low relative to their predictive value. So this is, you can imagine the lungs being very squashed. So total volume is quite low. Okay, this is peak flow. And on this peak flow chart, you can see there are different values for men and women. And it's based on your height and your age. So different lines for age. Okay, let's do me. So laser pointing not very good. So I'm 26, unfortunately, nearer to 30 than I am 20. So I'm 26 up here. I'm a man. And I'm probably about 177 centimetres. So I'll use 175. So I want to look at the blue line, and I'll go up on 26, all the way up here to hit the blue line and go across. My predicted value is around 610, something like that. My actual value, I'll be lucky if I get 580, and that's because I'm asthmatic. So my peak expiratory flow rate is reduced based on my predictive because I have asthma. So that's where peak flow is useful. It's not as good as spirometry. Spirometry is better, the gold standard if you like, but it's very useful, peak flow, because you can give patients a peak flow meter, they can go home and monitor it throughout the days and weeks, and you can monitor the response to treatment. And spirometry is very labour intensive, although spirometry is better because it removes the patient, removes some of the patient's enthusiasm, if you like, to do the test. You see people do peak flow and you ask them to take a big breath in and breathe out as hard and fast as they can, and they go, and you think, that's not very good, is it? So this is more patient, it can be influenced by the patient at peak flow. And you want, with people that try hard though, it's a good test. Okay. So that's data interpretation in a nutshell. We'll give you a couple minutes break for you to write notes, have a drink, or discuss with a friend for 4 minutes. For any questions, you can ask.